but I have a peculiar method. I look forward by looking backwards. I try to see where we've been and the lessons we've learned from yesterday and the day before and many years before that. And in particular, a year or two ago, the C.D. Howe Institute asked me to give a special lecture on the lessons we've learned about our healthcare system, because it's now been almost 45 years since universal Medicare was introduced in Canada. We have a lot of history with healthcare and trying to change it, trying to make it. We've learned some things that work, and we've learned many things that don't. And I'm going to play on what we've learned, and particularly the tension we have between the notion of equality and universality. It's striking how committed we are in Canada to equality of access to health care. That was what the introduction of Medicare was about in the 1960s. It was an attempt to strip away the problem of paying for health care so that people wouldn't be financially hindered, so they would have equality of access. All of our experience since then is that Canadians deeply value equality of access to health care. Almost all attempts to change the system in ways that would violate our commitment to equality have failed. Private health care is suspect in Canada because it's felt that it's a way in which the rich can use their money to jump the queue, and we won't allow that. All attempts, and there have been a lot of experiments at the provincial level, to try to suppress demand for the system by instituting user fees or co-payments have failed, because it has been seen again as a way of victimizing the sick, allowing the rich to get a freer ride. We're not going to give up equality of access to healthcare in Canada. We do know that costs have to be contained. And what's significant is that we now have 40 years of experience in trying to contain healthcare costs. The first Medicare came in about 1968. By 1971, people were saying the system is unsustainable and we have to reform it. And governments in the 1970s were talking about all the things that we so often hear today. We've got to switch from switch to preventive medicine. We've got to bring in nurse practitioners, other people. And we've had this litany of attempts to reform the system to make it more efficient ever since. For the most part, it hasn't worked. And the story of modern healthcare, not only in Canada, but in all advanced countries, is that healthcare expenses have a tendency to rise very fast and keep on rising. No country has been able to rein them in the long run. There are lots of reasons for this. I think the most important is that our people want healthcare. Healthcare really is a social good. As Dr. Turnbull said, it's not a drain on the economy. In fact, one of the best things you do as you become a rich country is you look after the health and welfare of your people. That's what John Kenneth Galbraith talked about in The Affluent Society, the kind of social spending that we should be doing. There is an enormous demand for health care, and I don't think it can be suppressed. I think our experiments at suppressing it have, for the most part, not worked. Now, Dr. Hurley showed that beautiful graph in which he showed that in the 90s, we did sort of manage to bring costs under control. And that's true. The 90s were the decade when, I guess they were the golden age of at least one school of health economists in Canada, the people who felt that you could control costs by reducing, by attacking the supply side of the equation. If you reduce the numbers of physicians, you would reduce the amount of billing. If you didn't bring in new diagnostic machines, you wouldn't have to pay for new diagnostic machines. And if you could keep on enforcing the Canada Health Act, you had a monopoly so that you could stop the growth of a private sector, and therefore under the monopoly you could begin to squeeze the system and you could get real results. The problem is that the system of the 90s was unsustainable. By the end of the 1990s, an enormous backlash had built up against the starving of our healthcare system. We were seeing, and polls showed, that the public was losing confidence in Canadian healthcare. People were getting really mad that they couldn't find doctors. They were getting really mad that they had to wait in lineups. They were getting even madder when they found that, as happens in a rationing system, people find ways of getting around the lineups, especially politicians. By the end of the 1990s, public confidence in the system was being lost. The private sector was growing, sometimes surreptitiously. Black markets were beginning to develop. And in fact, what had to happen is governments had to reconsider, back off, and we have now had a decade in which, for the most part, we've had the backlash, and a lot of money has been poured back into the system to try to keep the Canadian people happy. I don't think there are going to be any magic answers, but I think that we should rethink the meaning of equality and universality. The debate in the 1960s about healthcare was, if you're going to give everybody access, if you're going to give everybody equal access to healthcare, does that mean that you had to give everybody equal healthcare benefits? Some people said, why not just pay for the healthcare costs of the poor? Let the rich look after themselves. In fact, that makes a lot of sense. The problem was, and this was a problem that had developed in other areas of social policy, how do you determine who's rich? How do you determine who's poor? The governments, as they became more socially active, were bedeviled by the problem of means testing. And many people said, you just can't do it. You can't force people to sort of get down on their knees and beg for benefits. You'd better give social benefits to everybody. And so in the development of the early welfare state, our first old age pensions in Canada were universal old age pensions. Everybody got the same pension. Our child welfare policies were universal policies. Everybody got the same baby bonuses. And our health care was universal. Everybody got the same health care benefits, all of the necessary medical and hospital benefits they needed. Over time, governments under financial pressure found that it was possible, there were a lot of mechanisms to switch from universality to, in effect, means-tested social programs. We did it with the baby bonuses. You use the tax system, basically, to do it. With the baby bonuses, we abandoned the universal family allowance, and we put it on a needs basis. With old age pensions, we effectively abandoned the universal old age pension, and assistance to the aged is now put on a needs basis. I suggest to you that the most likely financial reform, and this is the answer to your question, I think, is that we're going to have to move away from giving benefits to everybody in the country, including all of those people who don't need them, and targeting our benefits on only those people who do need them. I think this is a crucial financial fiscal reform that needs to be done so that we can keep the system going. Yesterday, the Ontario government did a number of things in healthcare. It capped doctors' incomes. That's going to be politically contentious and probably will backfire. If they can make it work for 2 or 3 years, when the austerity ends, there'll be the catch-up increase and we'll be back where we were. They postponed hospital expansion. That's surely going to be contentious, especially in Mr. Hudak's riding, because were these proposals for hospital expansion not really necessary for the health of Ontario? Were they just frivolous and we don't need them? Or are we biting into something? But one thing they slipped in yesterday is the Ontario drug benefit. for seniors, which will now have a new deductible. The deductible will be doubled for people over a combined income of $160,000. And that, I suggest to you, is the wave of the future and where we're going to go in the financing of health care. We're going to put things like drug plans on increasingly on a means basis, and my guess is that governments are going to extend it, and Dr. Hurley's nodding. I hope he's agreeing with me, but he might not. I tend to be suspicious of some of the broader questions of equality of outcome that have been discussed today. I think it's very hard to get equality of outcome in health and welfare, because it seems to me the ideal of social equality involves enormous experiments in social engineering, some of which people here have been involved in, and I, as a historian, have my doubts, serious doubts. But I would say that if you want to do that, if you want to pour money into what you think of as other social determinants of health, it's all the more important that we forget about our false concept of universality. The rich can look after themselves. We don't need to be giving subsidies to bank presidents, maybe not even to highly pensioned university professors. If the aim of social policy is to help those in need, then money should go to people in need, not to people who aren't in need. Thank you.